Hello everybody, this is the vodcast on intellectual developmental disorder. As we've done for other topics, we're just going to begin with a review of normative development in the domain of cognition and intelligence, because with developmental psychopathology, we're always examining psychopathology within the context of normative and typical patterns of development. So just a reminder from other courses, I know you've studied what intelligence is and how it's defined. So just as a little refresher, intelligence includes the ability to understand complex ideas, to learn from experience, to adapt effectively to the environment, to engage in reasoning. It includes both basic mental tasks such as perception, as well as higher level skills such as problem solving, creativity, and planning. It also involves particular processes such as your processing speed and your ability to learn the pace at which you learn and understand things, and even your working memory capacity. There are three major different models of intelligence in terms of defining intelligence by its components, what comprises intelligence, not just the skills that are associated, but what are the components. So you might recall Spearman's G-factor view. So this is one of the historical perspectives suggesting that intelligence comes in one discrete package and it's a single unitary competence that explains all other skills and behaviors. So that's Spearman's G-factor, or general intelligence. Multiple intelligence, best known for Gardner's work on MI, or multiple intelligences theory, and Sternberg's triarchic model of intelligence, where there's three different intelligences. In this view of multiple intelligences, the idea is that there's not one package of intelligence, but a variety, implying that you could be very strong, for example, in Gardner's musical intelligence, very weak in interpersonal intelligence, and maybe somewhere in the middle in terms of your bodily kinesthetic intelligence. The hierarchy view of intelligences suggests that G is related in different ways to more specific skills and also to some broad factors. So the most common or well-known hierarchical model of intelligence is probably Carroll's three-stratum theory. This is pretty widely accepted today, I would say, in the field, the idea that there is some underlying G factor and it correlates to a greater or lesser degree with more specific skills such as vocabulary or math, reasoning, for example. All right. All right, so now this little girl, still in normative development here, this little girl is asking us, what are the nature and nurture-based influences on intelligence and cognitive development? So twin and adoption studies suggest that genes influence somewhere around 50% of the variation in intelligence. So we see pretty high heritability in intelligence. Some recent research suggests that the genetic contribution to intelligence becomes larger throughout development, sort of even more of the genetics sort of show up later in childhood and adolescence throughout the developmental period. So the idea would be that some of these genetic factors don't show up until later in developmental periods. But when they do, that's showing that genetic contribution getting even larger over time. Much of the individual differences in genetic aspects of intelligence pertain to brain structure and function, right? So we know that brain size is positively correlated with intelligence. We also know that much of our intellectual capabilities are housed in the prefrontal cortex, so we see individual differences there, and also individual differences in the dopamine system. And dopamine is a neurotransmitter linked to being imaginative, curious, and intellectual. From the nurture perspective, there are a variety of environmental factors that impact intelligence. So everything from maternal drug use or exposure to other terogens in the prenatal period, things like alcohol, drugs, radiation. Also, once the baby is born, the parental responsiveness to that child, how much the parents value education and academics, what their own level of education is comes into play, and even birth order. Poverty is probably the most widely discussed environmental factor that influences intelligence, and the mechanisms by which poverty influences intelligence are varied. Everything from nutrition and diet to the level of health care that children receive, and the amount of intellectual stimulation coming from parents and coming from home, and even the quality of neighborhoods and schools. All right. So now at this point, we are going to actually just review the specific disorder that's our focus today, intellectual developmental disorder, otherwise abbreviated as IDD. So we'll start with the DSM-5 criteria. The features of IDD, intellectual and adaptive functioning deficits in conceptual, social, and practical domains. So let's talk about what those domains mean. Conceptual basically means academic domains, things like reading and writing and other academic type of competencies. The social domain, your ability to relate to others, have empathy, communicate. And the practical domain relates to things like self-care and your ability to be independent and do things on your own. Get your own food, get yourself dressed, bathe, etc. So we see three criteria. In the case of IDD, all three of these diagnostic criteria need to be evident to get the diagnosis. So the first one here, deficits in intellectual functions, and there are some examples. Reasoning, problem solving, planning, abstract thinking, judgment, and learning. Deficits in adaptive functioning, the result in failure to meet developmental and sociocultural standards for independence and personal responsibility. So this is all considered in terms of same age peers, right? So what do we expect a 7-year-old to be able to do? Do we expect a 12-year-old to be able to get dressed on their own? Yes. Maybe even get themselves a snack, right? So that's what we mean by developmental and also sociocultural standards for independence. The deficits in this area need to limit functioning in one or more activities in daily life. So we might see communication issues, social participation might be interfered with, and an inability to live independently if we're talking about an adolescent or an adult. And the third criteria is that the onset needs to be during the developmental period. So in other words, during toddlerhood, childhood, adolescence is when we see the onset of these symptoms. When you get the diagnosis, there's a specification of degree and severity, right? So is it a mild IDD, moderate, severe, or profound? All right. Okay, so a few more of the kinds of sections of the DSM-5 that pertain to IDD. So how is IDD actually diagnosed? Well, through a combination of clinical assessments and standardized tests. As you might expect, some of those standardized tests are typically IQ tests, and typically 70 is the clinical cutoff score for mental retardation. So if you remember the bell curve of IQ, 100 is in the middle, and 2 standard deviations below would be 30 points below 100 or an IQ of 70. And with each standard deviation below that you continue to go down to 55 and then down to maybe 35, that's when you're getting into severe and profound intellectual disability. All right, so in terms of terminology here, the DSM actually even has a blurb where they explicitly point out that the term mental retardation is no longer used. Rose's Law is the reason why we no longer use mental retardation, so it's actually written out in public law. It's not used in the DSM, it's not used in journals. Intellectual disability or intellectual developmental disorder are the two socially acceptable terms to use, both for common use as well as in the medical community and in the psychiatric and psychological communities. Prevalence. We're looking at about 1% of the general population. There are more specific numbers that play out here if you're looking at different ages or if you're breaking it down by severity, mild to moderate, profound, etc. Those numbers change. But for our purposes, we can just know this 1% of the general population. What's the course and what does the developmental course look like and the trajectory? Well, if it's a severe case of IDD, you might see symptoms within the first 2 years. If it's a mild case, you may not see symptoms emerge until the school age years. When it's associated with a syndrome, something like Fragile X or Down syndrome, then you might even identify this IDD prenatally or shortly after birth, because many of the syndromes, many of the genetic disorders that also come with an IDD diagnosis tend to have unique physical characteristics that can be detected on ultrasound or shortly after birth. What is it comorbid with? Epilepsy, cerebral palsy, ADHD, depression, bipolar disorder, anxiety disorders, and autism. I fell over. Okay, so last two boards here that I want to discuss both pertain to the idea of etiology. All right, so with etiology, we're looking at cause. What's the pathway or the causal pathways that lead to the development of IDD? So first we're going to start with genetics, right? There are a number of genetically influenced forms of IDD, all right? And so a genotype focuses on the genetic causes, right? Having a particular gene sequence or having your genetics comprised in a certain way that you then end up having a behavioral phenotype that's associated with that unique genotype, right? So phenotypes are the set of behaviors that are displayed as a result of having a particular genotype or gene sequence. So 3 genetic disorders that explain maybe a genetic basis for IDD, right? So you could have a child who's diagnosed with Down syndrome, otherwise known as trisomy 21. It is something that occurs when there's an extra chromosome 21. There are unique physical characteristics, specific facial features, poor muscle tone, heart complications, language, insufficient language, especially in the area of expressive language or the ability to communicate with others. Another, in terms of temperament marker of Down syndrome, is that children with Down syndrome tend to be very happy and very sociable. Williams syndrome is another genetic disorder or syndrome associated with IDD and can be a cause of IDD. Described as a microdeletion on chromosome 7. General cognitive deficits are observed. However, there are very high strength areas which are in the domains of language and music. So you see some little music notes here. Children with Williams syndrome or individuals with Williams syndrome are known for their sparkling dispositions, their magnetic personalities. They have very high empathy, excellent theory of mind, especially in the realm of emotion, reading other people's emotions. They are socially disinhibited, right? So they're connecting very easily to a point where that could be seen as a fault to other people and to strangers that they don't know. Fragile X syndrome, a mutation on the fMRI gene, more common in boys. There are some physical characteristics, a large head as one of those. They tend to show behavioral difficulties, acting out, and some communication problems as well. But there's actually fewer consistently seen features in Fragile X syndrome compared to the other 2 that we just talked about. All right. And finally, another perspective on etiology. So beyond just looking at the genetics and the genetic disorders and the genotype view of the causes of IDD, here are some others that are clustered together by when they strike. So prenatal development before the baby is born. Perinatal specifically refers to the end of gestation. So 5 months gestation through 1 month after the baby's born, the perinatal period. And then postnatal, after the baby has been born, 1 month and beyond. So chromosomal and genetic disorders occur in the prenatal period, right? So those are the ones we were just speaking of. Other developmental disorders such as spina bifida. Fetal alcohol syndrome, when there is maternal exposure to alcohol, a result can be a medical diagnosis of fetal alcohol syndrome, which can be associated with IDD. Also inborn metabolic disorders. In the perinatal period, intrauterine disorders can result in premature birth, and so when a baby is born prematurely, they're at an increased risk. A neonatal disorder, so neonate is a newborn, such as a brain bleed or a hemorrhage. In the postnatal period, a traumatic brain injury can result in IDD. Infections, contracting different infections shortly after birth. Degenerative disorders such as Rett syndrome, which you might have heard of. Seizure disorders, exposure to toxins such as lead. So not even, we're not talking about teratogens here or that prenatal exposure, but later on. And also malnutrition, protein deficiencies, and extreme environmental or social deprivation. So that is IDD. And the last thing I just want to say about that is just keep in mind that IDD is the psychiatric or psychological disorder. Some of the things that we've talked about, Down syndrome, Williams syndrome, Rett syndrome, fetal alcohol syndrome, these are more medical diagnoses. So they don't have their own sections in the DSM. But when you have that medical diagnosis of some of these chromosomal disorders, you might also end up getting the psychiatric diagnosis of IDD. Thank you.